hour. I just want to remind you that we are going to be recording today's webinar. And also please turn off your sound while the presentations are going on. So the agenda for today is that we will begin with Pedro Mayra, who is going to talk about the Ativas project, a new paradigm on healthy living. And then we will continue with Antonio Cunha, who is going to talk about testing and experimentation facilities in health. And then we will end today's webinar with Christine Nielsen, who is going to tell us a bit more about how to use service design in strategic building projects. And then if we have time, we will take some Q&A in the end of the webinar. Before we begin with the presentations, I just want to tell you why we're here and why we are doing this webinar in the Excel Living project. So the Excel Living project focuses on habitats in a cross-sectorial dimension within home automation, welfare technology, lighting, furniture, and also building and construction materials. And what we are trying to do with these activities is to do an innovative program of webinars addressed to SMEs, but also other cluster members to increase your competitiveness and your internationalization opportunities, but essentially to enhance a smarter, more age-friendly and greener habitat value chain and its sectors. So in this webinar series, we have had topics within digitalization, technologies, management, sustainability, and internationalization. And after the webinar, you can find the recording and the presentation on the Excel Living Help Desk. And I also just want to promote this a little bit, because this is a platform where you can go in and you can meet other people who are also interested in the same topic as you are in the healthy, age-friendly, and sustainable living environments. So in here you have a forum where you can ask questions to a team of advisors. You can find all the webinars that we have held, and then you can network with other similar people. And so now we want to begin with the first presentation of today, and it's from Pedro Mayra, Senior Executive Board Member of IT Guest Group, and also CEO and researcher at Kentra Technologies. So I will just stop my presentation, and then you can share your screen, Pedro.
Hoping you can see my screen. Yes?
Yes, we can, and we can hear you as well.
Okay, thank you very much. It's good right now? It's okay?
Yeah, yes, it is.
Okay. Are you following my charts? Yes?
Yeah.
Okay. So Ativas is going to end as a project, as a research project at the end of this month. It will have a long life from them, because we have some patents going on, and we have some we just registered the trademark Ativas to follow as a business. But Ativas essentially was a research project that was focused on population health and active aging paradigms in cities, buildings, living spaces, and was really aimed to research and development, promote smart solutions that address these new changes in care paradigm. So we will know about what we are discussing about population health, about aging problems, about what's going on in Europe until 2030. This is what Activus was researching about. So main goals, and we discussed the full goals at the end. is to allow interactive and collaborating non-intrusive functional monitoring environment. So we work in interactive, non-intrusive functional, but monitoring, at least relevant monitoring environment. Try to transform and adapt and build healthy and safe smart building environments for active aging. So what we're going to do here is to transform a little bit, but build on top of smart constructions things that can be, for instance, health, public health environment, or just a main home environment in a collaboration mode. And strengths non-formal proximity care networks to set smart solutions. So we are building interactive and collaborative and non-intrusive functional monitoring related environments. But we also will take care about a global transformation in these non-formal proximity care networks to take care about these smart things. This is the consortium, and here you can see universities like University of Coimbra. Paulo belongs to the University of Coimbra, but you'll see here University of Aveiro, and we have a long time proximity with them. So EPN and Neuroinova and all these people come from university level. But we also see here companies like mine, which is Kentra, like Links, that is in working in health care for last 30 years. And you have see here several constructors and two important clusters like Habitat, Central Habitat, that is also an Excel living, and this for global engineering, electrical and electronic engineering cluster as well. So this is a good mix between companies, between well-known constructors like IKEA, telecommunication companies like NOS, and companies to promote this new care, new building stuff around the project. Project was structured in 5 pillars. So the social connected built-in environments that we are going to discuss a little bit in a few minutes. The integrating services and health living. So what's going on inside these geographical and these homes and these locations? Interactive and non-transitive environments about the virtual agents and technical helps and all things that are communicating with the end user inside homes. And then the sensor itself, and then the construction environments, the building blocks of constructions. So here you see things that are care about the civil construction and also the architects. Here is the building materials of the civil construction and the projects itself from the architects. Here are the people that are working in technical environments inside home and connecting all these sensors and from non-intrusive environments with all the integration systems that are connected at the end to the platform. So Ativas is if we need to say something very shortly, is this one: live well and healthy at your home with the quality that you deserve. This is Ativas, okay? Is changing the care paradigm underneath, okay? So what we are going on is moving from the conventional care that are basing into care silos. One is health care, and we know very well on the health care and all these things for a long, long time about care protocols and care pathways and ICT and telehealth infrastructure. And another one that is not very well worked on in Europe, which is social security silo. And here we have care plans, protocols, and these things are not connected to the health silo, at least in Portugal. So we have a dilemma that is important, that you have care persons that belongs to social security and belongs to healthcare, and these things are not well connected. So uh, we are giving the user empowerment or the patient empowerment to deliver the highest quality and high security care services and health integration services like this thing. We put care service coordination at the middle term. And what we did was integrated semantic data to access to home-based systems and have a joint response to ad hoc requests to a specific population, which is for Ativas, 65 years plus active persons, but sedentary one that are living in an environment, living in a region. So Ativas is putting a care coordination system on top of a region, which could be a county or a broader region, that we are doing coordination, coordinating all these systems inside the region. So now is the connected between population health and Activas is not really at a country level, but at a county or just a broader region to coordinate these services in a real-time communication, a real joint response to these two things: context-sensitive care service models in a health security intelligence services. So person is always inside building these coordination systems between health and health ministry and social security and social care ministry. And what you see inside home is vital signs sensor with comportamental sensor signs just collected. Nutrition, because it's part of these equations, and ambience sensors, all these four things inside home in this coordinated care environment. So about Ativas ecosystems, what we tried very hard to do is mix these formal care networks with informal care networks. So for the last years, we know about insurance, pharmacies, telecare, long care environments, hospitals, clinicals, transport, patient transport policies, policemen, but we know very little about how to push relatives inside these care networks, neighborhoods, non-government organizations, religious institutions, voluntary home support, all of this. There is a lot of information in this site, in this global care network that we mix and create records, social records, and mix with health records to take care about one system coordinating these both realities in just one ecosystem. And we promote this. This slide comes from Trevor Hancock, which is a researcher for University of Toronto, that was building this four axis of health mandala that we bring into Activas that has related employee and social economy, because we bring social economy into these projects. And we don't have time, but we can discuss about what type of new employment that we are bringing inside this these regions, connected physical environments to the regional ecosystems, healthy mix between health and well-being, and bring individual behaviors in the center of this equation, because these individual behaviors is the thing at the end that we're going to work and connect it and bring meaningful to these health and social records that we are collecting, that brings meaningful information about sensory homes and all these living environments. So, Ativas real addresses the real world in five things. One is the integrating digital platform and social registration. Then you have the home gateway and the things that related to technical health, technical helps that happens inside the home. And then you have the responsive furniture and built environments, and also the ceramical materials, the things that we are going to sense inside the home, which is ceramics and wood. And then at the end, you have the supporting habitat and active, safe, and health life, and all these business models that needs to be done that brings sense to this project after the research that ends at the end of this month and going to the market. Related with the platform and relevant clinical and social data, there are five things that we need to know. So we are aggregating information that I already discussed, from social environments, so from sensing things around not only for the home, but the inputs that we are gaining from the community. The platform was built from the democratization of this semantic and this interoperability. So is based on FHIR data model that we know for long time in the health. We create special records in social records and mix that health data models with social data models and democratize this information to give the community and the people that are related with these stakeholders information, relevant information about social and about health. Trust information that all of this information was worked at EU level about this is certified and secured to share to whom. So all this information are related, are trusted. Inform the proximity care networks about the relative significant events that they need to know, and tests are promoting the human functionalities through physical and cognitive stimulation. So we are all of these are bring to trust in very precise environments about reliability of this information, in this sense of it can be shareable or no, is trustable or not, in the way from social, from health, and from security. Global, our solution is based on a one platform. You know that all IoT and sensing environments are managed, built environments that are at a region level, connected to small communities at the council levels. And we have volunteers, caregiving, elderlies, and non-government organizations. So social responses to network proximity responses connected also to traditional healthcare services. Everything inside this social platform that connected services and promote just one place on all information goes and all events are thrown to these traditional actors. About applications, physical and cognitive simulation platform, care services application, nutrition applications, care volunteer applications, medical applications, everything inside one common platform. These are just two slides about this social platform. Runs everywhere. Everything is geo-references about each location that we are managing, person, location, physical location. These are things that are important to know about this Ativas project. So we collect from people the notion about patient-related person, which can be a relative or a caregiven person, a person itself, a group of persons, the practitioners and practitioners' roles. From Habitat is a collection of locations, locations inside locations, locations that belongs to organizations, healthcare services and social care services. So collect information about this. Sensors, we collect information about devices definitions, all the metrics and endpoints, things that we need to collect inside the location that are belong to organization that are related to a healthcare services or social care or social services, and this light in this area, everything that are related with the person. About events, appointments response, episodes of care, encounters, which are interaction between a patient and a social or a health provider, and flags that are things that happen from social alarm or something that belongs inside a home. So in these two slides, you see in a consolidated way information that are semantics that can be addressed from Activa's platform or any other platform that you want to integrate thing. Ativas will be open source, so you can use it. Is not it will give Activas to global community, so other people can work around it, build and construct a new type of integrations. So if we see the platform and now we see the integrated ecosystems. So these are the location. This is the home gateway that is specifically built to collect anything that are on the location, from sensors, detection of deviation values. So it's doing data collection and very scene analysis that what is going inside the intelligent home, and communicated with the whole platform these events, and getting from the platform things that are important inside home to manage. So notifications, virtual and robotic artificial intelligence helps, and everything, of course, is belong to social platform. So sensing, small detection of default deviation, doing some data collection and analysis, getting doing first notification or receiving from the platform notifications to the virtual and artificial agents.
Pedro, you have a few more minutes, then you have to
We
give
are,
the
oh,
word.
yes, yeah, we are. I'm just finished. So
Thank you.
artificial intelligence agents. I think Paulo is going into this side. So I'm not address this here. Just to give you a little bit notion about what was built inside Ativas, the home gateway itself, which is a product of Ativas, what kind of sensors, commercial sensors that is going, is the first ones that are going here, vibration, temperature and humidity, touch, flood, gases, and all the domotics that are inside home. And these are examples of modular constructions that we built from Ativas. And finally, the goals, the 8 goals, and this is the last slide that is here. So, first one, develop a concept of habitat providing with adaptability with the needs of different age groups. So, the habitat itself and this, the construction itself. Understanding the key factors of health and well-being and illness, and transform these key factors in records, in relevant information that we can give to the various stakeholders that are involved in Ativas. Prevent and treat diseases of seniors. So we have a lot of these models trying to around nutrition, about medication, about physical and cognitive things. We had a lot of this. Encourage active aging, self-management, health. So the person on the top is the patient itself. Organize informal methods and healthcare, mix these two reality from social records and health records, and deliver health records and informal records in integrated care model effectively. Yes, a common platform for both realities. Reduce the existing gap between senior population and others. So bring to community involved in this project in the region. In fact, of the end of isolation and senior population. Why? Because we are censoring, giving these homes and home sensing in home care model inside the community in not senior silos to just to take care of this population. I think that's it.
Thank you so much, Pedro, for telling us about Ativas. It's quite an impressive project that you have been a part of. And if any of you have questions, let's wait until the end, and then we can take them at the Q&A session. Will you stop sharing your screen again, Pedro?
Yeah.
Great. So thank you so much. And now we'll move on to another perspective of this topic and another way of testing solutions and to increase the performance of health innovation chain. And it will be Antonio Cunha, who is an automatics lab executive director of Institute Pedro Nunes, who will be sharing this information with us. So the word is yours, Antonio.
Very well. Can you hear me?
Yes.
Yes, and can you see my presentation in
Yes.
full mode? Okay. Yes, I think that my presentation is a little bit more in the downstream, comparing with Pedro, right? Because the idea is not to develop the solutions, is to create like some facilities to test this type of solutions, in fact. Even or before to give you some detail about the test facilities that we are set up here, maybe to create or justify why we are doing that. Let me check. Okay. Because this is our vision. Maybe you know this figure. It was invented in north of Netherlands, but it's quite easy to understand. The objective is to live longer with health, right? And to achieve that, we have two main variables. We have the prevention and the intervention. If we do a good job in the prevention, maybe we can have some impact in the intervention, right? What we need to avoid is this worst case scenario. It's like this curve, right? When we have when we live longer without health. Our perspective or our belief is that that in fact the technology could help in this in sustain this curve somehow. Could help, but it's not enough. The technology. Okay, why? Look to this example. In European medtech sector has around 27,000 companies, 95% of which are SMEs. And these companies need to demonstrate not that they are producing safety or solutions with performance, but they need to prove that in fact what they are doing produce impact or have some impact in the clinical perspective, right? But this journey is very, very hard and could, for example, it's a variation, but somehow could be between 18 and 24 months. This is huge for a startup. This journey could somehow kill the company in the meanwhile, right? Then that's why we need to create this capacity to help the startups not only in the developing phase, but in the downstream phase, okay, in the validation, certification, and so on. Another somehow topic that I want to share with you is more than 300,000 health applications exist with more than 200 added daily. Then if you look to the main markets, you will see 200 new applications every day related with health, okay? But, for example, using only the diabetes case, a recent evaluation of 280 diabetes mobile applications found only 5 are associated with the clinical outcomes. Then maybe you agree with me that it's a lot of garbage, right? We are producing a lot of things, but in fact we cannot prove that these solutions have impact in society and in this particular case have impact in health. Then the problem is for sure it's not in technology capacity, is in the adoption, right? It's a quite old slide, but somehow it's still actual or is still updated because in fact we didn't solve this problem of adoption. You can see other representation of this, a lot of technology capacity, a lot of needs from the market, but we don't know why, but sometimes we cannot cross these two ambitions, right? This is here another representation, not using the technology readiness level, that is, in our opinion, it's quite poor. We are using a different representation in health, is a methodology from US, but in the end we have also different steps: clinical need, idea, proof of concept, proof of feasibility, and so. But the interesting thing in this methodology is that it's not only the maturity of technology, all the process runs in 4 layers. Then in each part of the project, we need to classify the clinical perspective, the market, regulatory, and technology. Then since the beginning, we cannot only think in the technology perspective. It's mandatory to somehow to think in 4 different layers since the beginning. Then our initiative that I will present you in the next slides wants to mitigate this gap between the proof of concepts, pilot, and the proof of feasibility. Okay, this is our focus. Then, what we are doing with these testing facilities, we are creating a single door between the startups and the caregivers, namely the hospitals, primary care, home care, of course the community. And the idea here is organize the services, because a startup, it's not really new. A startup could test something in the hospital, but to do that, you need to know someone, right? Because the process is not organized. The hospitals don't have like this common door, or they are more focused in providing services, because of course they exist to provide services, and they don't have like this specific interface to connect with startups. Okay, then what we want to explore is that to use these very big organizations also to have impact not only in health of the society, but also to create some impact in the economical aspect, helping the startups. Okay, then this is what we want to explore. But you know, we have a lot of initiatives. We have living labs, digital innovation hubs, laboratories, project demonstrators, a lot. This real-world test bed is what is somehow the uniqueness of this. The idea is only to test solutions with quite high maturity. The idea is to start in TRL 6 when we cannot put nothing inside of the hospital without at least with this TRL 6 level. And also, of course, the aim is to test in real world environment. Then we have this intersection, real world environment and maturity. Okay, then we need to cross these two different things. I think I will jump. If you have some curiosity about this methodology, you can put in the Google CIMIT model and you will find this methodology. And we want to have impact between the proof of feasibility and also the validation of the solution, that is the level 7. Then the testing and experimentation facilities is to have to create to improve the chain in these 4 different steps. Then this is an European project, a quite large one. We have 7 places of tests. We are leading the Portuguese node, where we have 2 quite big hospitals. We have the University Hospital here in Coimbra, and also we have Hospital São João in Porto. Then we are helping these 2 big hospitals to create this single door that I referred before. But we have more countries. We have France, Italy, Germany, Sweden. We have these 7 nodes. This project is coordinated by the Charité in Berlin, and the objective here is to achieve some differentiation in the different nodes. For example, our differentiation here in Portugal will be the robotics. The idea is to have some specific facilities here, for example, in order to attract a French company that wants to test something using robotics. We have these specific facilities here. If, for example, a startup wants to test something in Internet of Things, need to select, for example, another node because it's the expertise of another node. But in the end, yes, we have these 7 test sites in Europe. Yeah, because what we want to provide to the SMEs, first we want to have access to the patients, right? With the center applications that could be patient-centered, with different contexts, with physical, of course, inside of the hospital, but for example, with some virtual capacity also. It's the case of using data. For example, a startup could use the data even if it's not inside of the hospital. Then we have these 2 different facilities, physical and virtual. The validation and impact assessment, it's very, very important here to prove and have the methodology to help the startups to prove that in fact the invention has some value, because it's achieving a specific health outcome. Then it's not magic, this part. We have like a methodology and we can support the startups to have this assessment. And for example, it will be useful to attract investment, to prove to the investors that in fact this solution has some meaningful. Of course, the strong involvement of patients, the professionals, payers. The payers here, it's very important. I will come back to this in another point, because you know normally the society don't want to pay for health services, right? We expect that the state somehow finance all the tasks related with health. Then that's why we need to understand very well since the beginning the payer or the reimbursement schemes, because if not, a startup when have the product ready and validated, go to the market and will realize that in fact these specific products don't fit with the reimbursement scheme and will be a mess because they will not sell for sure. Okay. Of course, the regulatory sandbox. This is a very important thing, because you know the health is quite regulated. Then we need to create like a specific environment. Maybe I can say that with very specific rules in order to not to block a specific solution because the regulatory issue. Okay, then that's why it's very important to have a very good relation with national authority and also with the ethical committees, and so to facilitate this process. Of course, certification and ethical support. Again, the connection between the ethical committees and regulators. Physical facilities, of course, to have some space inside of the hospitals to receive the companies is very important. Also, provide clinical health data. It's and here we have two main aspects. Of course, to give access to the data, but it's not enough. We need to care about the liability. For example, we have some cases that the hospital is available to provide the data, but startups don't want to use the data because they cannot assure the liability process. Okay, then we want to have impact here also in the giving access, but also be sure that the startups could use the data without problems in the future. Again, the reimbursement schemes in the different regions, because the reimbursement scheme is in Portugal is different when we compare with France or in Germany. That's why we need to understand these rules since the beginning and say to startup, look, even in the beginning, you need to look to the list of the reimbursement solutions and try to align since the beginning your solution with the reimbursement scheme. And I think it's more or less that. I will not want to spend a lot of time, but I hope that you have I hope you understood somehow what the test facilities could help in your journey. Okay.
Thank you so much, Antonio. And yeah, you're right. It's really important to facilitate these test opportunities and to make sure that it's a single entry point. So it's really interesting to hear how you have done it. So now we've spoken about how to put technologies into construction from the beginning and see it as a whole, and how to make the best test facilities. And now we'll also have Christine Nielsen telling us about how to involve the users in these type of projects, and in this case a construction project here in Denmark. So Christine, you're welcome to share your slides, and the word is yours.
Thank you. Just a second. I'm trying.
Yeah. Otherwise, I can share them if you are having issues.
It doesn't seem to pop up on my sharing option.
Oh.
I got my presentation open. You can share it if you don't mind.
Yeah, I will do that. Let me just find it. And
I can hear someone's microphone is still turned on.
So, can you see the screen now?
Yep.
Perfect.
All right. So I'll talk about the use of service design in strategic building projects, mainly strategic planning projects, really, rather than construction. But I'll get back to that. My name is Christine. I'm an architect. I've been contributing to the planning and development of a variety of healthcare architecture in the region of southern Denmark. Before working with that, I worked with international master planning and large-scale projects. So I'll just give you a brief introduction to the Health Innovation Center of Southern Denmark. And following that, I will talk about the concept of service design. And then I'll show you how we've used service design in analyzing the diverse landscape of Kerteminde municipalities, citizens, and using it as a tool in facilitating the city council of the municipality into getting a shared understanding of the complexity of the life for their elderly citizens. And you can click twice, actually. I forgot to tell you, that's me. Yep. Thank you. So the Health Innovation Center is part of the region of Southern Denmark. We offer a range of services to support our clients, patients and stakeholders. We act as project facilitators, managing and overseeing programs or projects implementation. We offer consultancy services. We focus on user involvement, product service testing and development. And we assist in securing funding for innovative projects. And also we serve as a central hub for healthcare innovation, knowledge and know-how. And please, next one. So we work with healthcare architecture. It's one of our strategic business area or main focus areas. We believe that good healthcare architecture is based on a holistic approach, which integrates functionality, aesthetics, use and maintenance. We always focus on the user experience, and the user here is being both patients, citizens, clinicians, all stakeholders really. We believe that a holistic approach to the planning of future constructions and strategic planning projects contributes to more sustainable and flexible solutions. And next one, please. And sorry if I speak a bit too quickly. I know time is running, so that's why.
It's okay. You have all the time that you need. People can send the questions afterwards to you instead.
Sure. And I believe you can just click one more time, then they'll pop up a small picture. Yeah, right. So our projects range from co-facilitating large-scale constructions like the University Hospital in Odense, in Denmark, to smaller scale projects like nursing homes, rehabilitation centers, and so on. But regardless of the size of the project, it's our main task to facilitate a large variety of stakeholders throughout the process and always balance the opportunities and needs against each other, and to bring operational considerations into play and to ensure the most sustainable, flexible solution. We believe that this is best done through a thorough involvement of the users and the methods from service design. So now we'll get to it. So please click for the next slide. Yeah. So this is just a quick image of service design. Maybe some of you know it. We perceive architecture not only as a physical framework for healthcare, but also as a catalyst for positive change for both patients, employees, citizens, and so on. Service design to us is both an action, it's an approach to understanding design, and it's a toolkit of methods. It combines both what we do and how we do it. By viewing architecture as an integral part of a service, it becomes an active agent in addressing the challenges we encounter in healthcare. And this might involve designing a building layout that support optimized workflows, could be minimizing the time clinicians spend moving around the building. What touch points do they meet during the day? As such, a service is never just something that happens. It's a series of events over time, and it's all of these things that create value. And as you'll see, service design can also be used when looking at a period of a citizen's life, a user journey through a patient's life. Yeah, so please click for the next one. Thank you. The tool we use in service design is mainly visual tools that help us illustrate the service, and it helps us create a common understanding of a situation amongst participants in the design process. It can help us see the service as a whole, and it can create an overview, and it can zoom in on a certain touch point. We create user journeys, personas, and service blueprints, and we look for patterns through system thinking and ecosystems. Yeah, next one, please. So now to the example that I've picked. We use service design in a variety of projects, almost always. This is a project that we did a few years ago, and the result of this was a presentation and a proposal that centered around nursing homes in Kerteminde municipality, a small municipality in Denmark. This is not a research project, this is only qualitative studies. Next one, please. So in Kerteminde, as well as everywhere else, we're currently faced with 3 key challenges in elderly care. This goes for Kerteminde too. Firstly, there's a shortage of younger generations available to care for aging population. We all know that. Secondly, a constrained economy poses difficulties in planning and construction nursing homes. And lastly, recruiting and retaining nursing staff is a huge challenge, very big in Denmark as well. Next one, please. So our main objective was to explore 2 key questions. Can the timing of transitioning to nursing homes be postponed because this would cause less strain on the municipality's finances? And also, what constitutes a good quality of life for elderly citizens in Kerteminde? So to create this, we conducted an analysis, qualitative analysis of the aging population's needs, their preferences and resources. And yeah, next one, please. Yeah, so what we did was to create 6 personas, citizen profiles, and we examined their typical life path. All of these 6 personas were people living in nursing homes. The profiles and life paths could be used dynamically and repeatedly for the establishment of new nursing homes. They could create an opportunity to work with the assistance offered to citizens by generating understanding, curiosity, and perhaps new ideas. Next one, please. So we did this sort of mandala, like Pedro showed as well, just slightly different. So in assessing the resources of these elderly citizens, we considered several key parameters. Through the evaluation of all 6 representative citizens, we gained a shared understanding of the significant diversity among the elderly in Kerteminde by considering their health, family network, daily assistance, mobility, etc., etc. It's all shown there. We obtained valuable insights into the wide range of experiences and needs within this population. Being old is not just being old. We have the same preferences as we used to have. Next one, please. So as an example, and this is this life journey, user journey we did for all 6 representatives. We focused in this one in Søren, who's married to Helene. So we looked at the services and support that Søren would typically receive from the municipality, which is, this is very small to you, I'm sure, but I'm going to talk you a bit through it. Let's look at their story. We meet Søren and Helena at the now line in the middle, and we look into what would typically happen before that now line and after that now line. We do this to be able to imagine what could have been done earlier and to discuss how we can improve a likely future. So this is Søren. He's 89. He's a retired engineer. He undergoes prostate cancer checkups, but he's doing fine. He resides in a spacious apartment at now. He still remains active as a volunteer. And then he's married to Helene, who is 91 and suffers from advanced Alzheimer's. She now lives in a nursing home, in a one-room nursing home with a local care center. And despite the financial challenges of managing the two rent payments, they're doing quite okay because they're shared pension. They have a supportive family, although their children and grandchildren live quite far away. Søren is quite comfortable with technology and uses it for social media engagement. He's quite good at that. He relies on his son for transportation. Furthermore, the municipality provides services and support to assist them both in their daily lives. So, at now, Søren's everyday life revolves mostly around Helena and the activities he participates in as a volunteer around the nursing home. So we did this life journey. We worked with the local council, and we used this in a workshop for them to play around with what could have been done earlier, or how could we change a likely future for these couple. And some of the questions that would come up during this sort of workshop would be, how do we facilitate a good journey, life journey for Søren, so he can be close to Helene? How could he be supported in moving to a more suitable housing? Could he be assisted in maintaining necessary mobility? Could he be supported in nurturing the social relationship he has formed as a volunteer? And so on and so on. And who is responsible, and how do we do this? Next one, please. Time is running. Very quickly, what service design can do is to create this shared understanding. It creates a shared empathy for a municipality council, no matter what preferences or references they have with politics or private preferences. And this gives I'm just going to skip to my last, just hold on to this one. Yeah. Sure, fine, yeah, sure, that's all right. So we use service design to facilitate this shared sense of empathy and understanding among the council members. And throughout the process, we gain valuable insights into the challenges and aspirations of the elderly citizens. In conclusion, service design has played a crucial role in cultivating a deeper understanding of the elderly citizens in Kerteminde Kommune. That's it. Sorry, 3 minutes left.
Thank you, and no need to apologize. I was thinking that all the presentations were so interesting, so I gave you the extra minute, all of you, to speak, and then we can have questions in emails instead if anyone is curious. But we have 2 minutes. If someone is really having a question they need to ask in the webinar, otherwise I will share the email addresses with everyone afterwards.
I have
Victor.
one. Yeah, I'm always talking at the end of the webinar. So
yeah.
No, just 3 very quick questions to one of them. To each one of them. Pedro, what clients are you expecting for this architecture? Antonio, all your experience about this making life easier for the startups. What were the critical factors in this helping them through the bridge for not falling in the middle? And Kristen, I found very interesting this part of postponing the last change of from the their usual residence to their lifetime residence to the nursing home and try. So what would you say? It's from your experience in all these inquiries that you made. What was the one strong critical factor that contributes to that? Because either for Antonio and you, I think you have a common point that it's you have to deal with a lot of information and data gathering about this, all these informal care network that have to be activated. Is this a big trouble for the municipality dealing with this? Is this manageable? I don't know. It's something I'd like to what you point out as a critical factor.
You can
Do we
begin,
have time
Christine.
for this, or should we get in touch afterwards?
If you have time to stay on, I
No,
have
just a
time as
short
well.
question,
So
I don't think they have the capability to manage this. I find it very interesting discussion. What I didn't get the time to talk about was the fact that we make the change to transition through our housing options in life in time. We always do it too late, and that makes moving and transitioning even harder. And that is why you need a couple of years in order to establish relations with your neighbors and friends. And that happens too late, because once you start moving, your mobility decreases, and you're not able to get those relations that you need in order to live a good life, and it leads to loneliness, which is a huge problem. So I find it very interesting. I would like to create parts of cities and societies where we can live throughout our lives without having to moving into nursing homes, but that the local community can take care of us in a home that is built for you to live in, even though you lose mobility and loss of function.
So
That's my
local
dream.
policies have a great effect here. Local policies, right? Have
Sure,
a strong
absolutely.
effect. Yeah.
Yeah.
Thank you. Antonio,
thank you.
how do you manage this?
I think maybe the key issue here is that somehow the different speeds between, for example, the reimbursement entity that somehow classify what type of solutions they will reimburse in the future, and also the availability of the solutions. What I'm trying to say is that a company could have already a quite innovative digital therapeutics, but somehow if it's not covered, they will not have business. Then they are working in different speeds. That's why we need to have like a green way to validate this type of digital therapeutics quite fast. Okay, this is somehow the synchronization between the reimbursement and the availability of the solutions.
And this raises the final question, which is based on this, Pedro. Who are your clients, and is there a request for them for this kind of Ativa solutions?
Yes, my clients on the public sector are municipalities for sure, and all these local policies and all these things that my colleagues were discussing about. On the private sectors are senior residencies groups like Montpellier that is putting some pressure over us, and all these big groups that are handling these senior and long-term residencies for seniors. Some hotel groups that are in thermal facilities that now are more investing in health being and some other kind of tourism, especially in Portugal, that are some tendencies for these new constructions, sensitive constructions, and the complete services. So, public sector for sure, counties and municipalities. Private groups that are right now working with the senior persons on VIP side, and at hotel groups that are demanding from health tourism and health being tourism, and that includes some thermal facilities right now in Portugal. That's what I'm looking for.
Thank you.
Thank you so much. And now I think we have to end the webinar. So I will share the email address of our 3 speakers. So if anyone has questions, they can send an email. And again, thank you to all 3 of you for providing us some interesting perspectives on this topic. And yeah, thank you so much, and have a good afternoon, all of you.
Okay.
Thank you.
Thank you. Thank you.
Bye-bye.